When we hear the word hoarding, a certain image often comes to mind, doesn't it? Maybe some scene from TV or, stories about a neighbor's house overflowing.
Yeah, mountains of stuff, clutter everywhere. Somebody just can't let go.
Exactly. But what our sources are revealing today is, well, it's a much more intricate, deeply human, and honestly often heartbreaking reality that goes way, way deeper than just a messy room.
It really does.
So today, we're going to properly unpack hoarding disorder. Our mission for this deep dive is to get past those stereotypes, those surface-level ideas, and give you, our listener, a clearer, more empathetic, and just a really thoroughly informed perspective. We'll be digging into, academic research, psychological analyses, practical guides on how to actually help, basically trying to understand what's really happening beneath all that clutter.
And the impact it has, which can be huge.
Definitely. So we'll start by defining it, making some distinctions that might actually surprise you. Then we'll look at the roots, genetics, brain stuff.
Yeah, the neuroscience is fascinating.
Then we'll look at other conditions that often go alongside it, challenges for older adults, and finally, what actually helps? What are the pathways to support?
Sounds like a comprehensive journey.
Okay, let's unpack this then. Our sources draw this really crucial line between, say, a passion for collecting things and the much more complex reality of hoarding disorder. On the surface, maybe they look similar, lots of stuff involved, but the why and the what happens next are totally different.
It's fascinating, isn't it, how our relationship with just objects can go in such different directions. The sources point out that collecting, like true collecting, is often driven by some pretty deep human motivations, sometimes even primal ones.
Primal? Like what?
Well, a collection can be like an extension of your identity, right? A tangible piece of who you are, maybe a way to feel like something of you lives on, think family heirlooms, or maybe art that shows your taste.
Okay, yeah, I get that. Makes sense.
And then there's this psychoanalytic idea that maybe for some people, especially if they felt insecure or maybe unloved as kids, collecting stuff provides comfort. It's like a substitute for connection, or maybe a way to build a world they can control.
A sense of security through things?
Exactly. And even further back, some evolutionary folks suggest that accumulating resources think valuable collections might have been a signal way back when, like showing you're a good provider, able to attract a mate.
Huh. From survival instinct to personal comfort, that's quite a range for just collecting things. And collectors, they tend to be pretty deliberate about it, wouldn't you say? They choose things, display them, organize them.
Precisely.
Yeah.
They curate.
Yeah.
They often share their passion, connect with others. It's about excluding things, too, focusing on specific types, quality, rarity. There's an order to it.
Right. And that's where the contrast with hoarding really starts to show up based on the sources. A hoard is described as omnivorous. It just takes everything in.
Indiscriminate, yeah. And unlike that collection you proudly display, hoards are often hidden, tucked away, rooms overflowing behind closed doors. There's often a lot of shame involved, which makes people secretive.
So when does that passion cross the line? Professor Randy Frost, who's a major name in this research, he put it pretty starkly. He said, a passion for collecting is a healthy outlet, but it can become a deadly enterprise when it crosses the line into hoarding. Deadly enterprise, that's strong language. What makes it deadly?
It points to how severe the consequences can get. Social isolation, financial trouble, serious health risks, safety hazards. It can really escalate. And, our sources talk about these psychological tendencies we all kind of have that can blur those lines you mentioned.
Like what kind of tendencies?
Well, take the endowment effect. That's our bias, where we just value things more because we own them. Suddenly, your old mug seems way more valuable than the identical one in the shop.
Right. We get attached just by owning it.
Yeah. And then there's contagion. Think about celebrity memorabilia. People want it because it feels like it's got the essence of the famous person. Now, these aren't problems on their own, but mix them with a really persistent, intense difficulty letting go. And that fuzzy boundary snaps into sharp focus.
So the analysis really lands on that persistent difficulty discarding or parting with possessions, regardless of their actual value. It's not about the monetary worth. It's that deep internal struggle.
Exactly. Even if they do discard some things, maybe under pressure, that core difficulty is still there. And here's the really tricky part we need to understand. Often, the person themselves doesn't see it as a major problem, or they rationalize it. That lack of insight is a massive hurdle.
That lack of insight is key, isn't it? It separates hoarding from a lot of other conditions where people know they're distressed. And it brings up the environment too, like how much does just having space matter?
It's definitely a factor the sources acknowledge. If you had infinite space, maybe a collection could just keep growing without impacting daily life immediately. But most of us don't.
Right. Finite space?
So when the stuff starts taking over active living areas,
Yeah.
the kitchen, the bedroom, hallways, so you can't actually use them for what they're for, that's a huge red flag. It's about function, safety, hygiene, not just the amount of stuff.
Which brings us right to the official definition, the DSM-5 definition of hoarding disorder. And this was a big deal, right? Because the DSM-5, back in 2013, made it its own separate diagnosis.
Huge deal. It's separated out from OCD, where it used to be kind of lumped in as a subtype or symptom. This distinction is critical because it signals we're dealing with something unique, needing its own specific understanding, and, really importantly, its own tailored treatments.
Okay, so it really changes how we think about it and how we help.
Absolutely. And what's fascinating about the official definition is how much it emphasizes the impairment and the distress the accumulation causes, not just, how many things someone has, which leads to that big question, why? Why do people develop such this? Profound emotional attachment to things, often regardless of any objective value. The DSM-5 gives us 6 core criteria.
Let's walk through those because they really clarify what we mean by hoarding disorder from a clinical standpoint. So number 1 is that persistent difficulty discarding or parting with possessions, no matter their actual value. It's that intense internal struggle, the pain tied to letting go.
Right. It's not about laziness or being messy. It's about anguish at the thought of discarding.
Okay, and the second criterion?
That this difficulty comes from really strong urges to save things and/or significant distress associated with even thinking about discarding them. It's that anticipatory anxiety, that fear of loss or regret that makes it so hard to even start.
Got it. A powerful emotional barrier. What's number 3?
The visible result, accumulating so many possessions that they clutter up active living areas, making them unusable for their intended purpose. And the sources add that if those areas are cleared, it's usually because someone else, family professionals, intervened. The person typically isn't doing it themselves.
Okay. And the fourth criterion really hits home the impact, right?
Yes, this is key. The symptoms have to cause clinically significant distress or impairment in important areas of life: social, work, safety, health. This is where it crosses from cluttered into a clinical disorder. Maybe someone's too ashamed to have people over, or they can't use their kitchen safely, or it affects their job.
And the last 2 are about ruling other things out.
Exactly. Fifth, the hoarding isn't because of another medical condition, like a traumatic brain injury affecting decision-making. And sixth, it's not better explained by symptoms of another mental disorder, like delusions and schizophrenia, where someone might believe their items have special powers. It ensures we're diagnosing hoarding disorder specifically.
Okay, that's a clear framework. And there are specifiers, too.
Yeah, just briefly. One is excessive acquisition, so not just difficulty discarding, but also compulsively acquiring things, buying, collecting free stuff, sometimes even stealing. It's an active seeking out of more items.
Right, the incoming side of the problem.
And the other specifier is insight. This is crucial. It ranges from good insight, where the person recognizes the problem, to poor insight, where they mostly don't see it, down to absent insight, or even delusional beliefs where they're completely convinced there's no issue, or their items are uniquely valuable or important in an unrealistic way. Poor insight, as we said, is incredibly common and makes getting help so much harder.
That makes total sense. So it's not just having loads of stuff. It's that persistent difficulty letting go, the distress, the real-world impact, and often that lack of recognition. This really is its own distinct thing. Which brings us back to that question. Why this profound emotional attachment?
The sources dig into this, explaining it as a profound emotional attachment to inanimate objects. And these aren't just random feelings. They're deeply tied to our psychological makeup, our attachment styles formed over years. It's complex.
So it's less about the object itself and more about what it represents.
Precisely. Our sources list several reasons why we all form attachments to things, but these get amplified in hoarding. Sentimental value is a big one. An object representing a memory, a person, a significant event, a gift, something from childhood.
But for someone with hoarding disorder, maybe one memento turns into boxes and boxes related to that memory.
Exactly. Each piece feels irreplaceable. And objects can also feel like symbols of stability, comfort, especially when the world feels chaotic. They offer security, a constant thing. If life feels overwhelming, possessions can become this kind of predictable, controllable zone, even if it's dysfunctional.
And then there's attributing feelings to objects, personification.
Yes. seeing items almost as alive or as companions. That old sweater isn't just fabric. It kept me warm, so it deserves to be kept. It taps into nostalgia, comfort, identity, all normal human experiences, but taken to an extreme.
And crucially, the sources mention possessions acting as a coping mechanism, like avoiding deeper stuff.
Absolutely. A way to avoid facing intense loneliness, unresolved grief, past traumas. Accumulating things can literally fill emotional voids left by difficult relationships or deep insecurity. It's emotional avoidance. The attachment to objects becomes tangled up with unresolved emotional pain, making letting go of the items feel like letting go of something emotionally vital or facing something too painful. It's like a shield.
That deep emotional connection really makes you wonder about the origins, the roots of this. What does the research say about why this happens? It feels like more than just behavior.
Oh, definitely. And one of the first things people ask is it genetic? Research strongly suggests yes, hoarding runs in families. This isn't just anecdote. The stats are compelling. It shifts the focus from blaming the individual to understanding a biological predisposition.
So if Great Aunt Mildred's house was packed to the rafters, there might be a real genetic link there. The numbers are pretty striking, aren't they?
They really are. Somewhere between 50 and 85% of people who hoard report having a first-degree relative, parent, sibling, child who's also a pack rat or hoards. And a big chunk, 26 to 54%, report family members with OCD, though we need to be careful with that connection.
We'll come back to the OCD distinction, but genetically, how strong is the link?
Well, the heritability estimates are around 71%. That's high. Similar to, or even higher than, conditions like depression or anxiety. A big twin study found genetic factors accounted for half the variation in hoarding behaviors. It really points to a strong inherited component, alongside environmental factors, of course.
And these genetic studies also support the idea that hoarding is different from OCD.
Yes, that's a key finding. While they can co-occur, the genetic markers suggest they are distinct conditions, likely arising from different underlying biological pathways, which reinforces why the DSM-5 separated them.
Okay. And what about when hoarding starts? Does it appear later in life?
Actually, no. Research shows symptoms typically start surprisingly early, always before age 30, and often much earlier, like around 13 or 14. It's not usually something that just pops up when someone's older. The patterns start forming young.
If we connect this to the bigger picture, that early onset, plus the fact that it tends to get worse over time, it really highlights the need for early identification, doesn't it? Which must be tough, given the insight issue.
Exactly. Severity tends to increase with age if there's no intervention. What starts small in adolescence can become overwhelming decades later. And tragically, hoarding is grossly underdetected and untreated. One study found only 2 out of 13 people with hoarding issues were getting any kind of support. It's a massive hidden problem.
Now, this next part is really fascinating, the brain science behind it, the neuropsychology. Research points to differences in brain function, right? Particularly in areas like the anterior cingulate cortex, the ACC.
Yes, the ACC and other related prefrontal areas show differences. Brain imaging studies find abnormal activation patterns in these regions. These parts of the brain are normally involved in really important stuff like error monitoring, noticing when things aren't right or you've made a mistake.
Okay.
They also help weigh the value of things, assess risks, manage difficult feelings. So in hoarding disorder, the brain might not be flagging the error of too much stuff, or it might generate overwhelming distress at the risk of discarding something worthless. It suggests the struggle isn't just willpower. It's rooted in how the brain is processing information and emotion.
So it's not just a matter of willpower or tidiness. There are actual brain differences making discarding incredibly difficult. Let's break down some of those specific processing issues. First, attention. Sources say people with hoarding are distractible, often showing more symptoms of ADHD, specifically the inattentive type.
That's right. Not hyperactivity, but trouble with sustained focus, easily getting sidetracked, difficulty with spatial attention. Imagine trying to sort a huge pile of mixed items when your focus keeps drifting. It makes organizing incredibly hard.
And what about memory?
This is interesting. People often report needing to keep things in sight so they don't forget them. There's evidence of biased memory beliefs, meaning they lack confidence in their memory and overestimate how bad it would be if they forgot something.
Like holding on to every single bill because they're terrified they'll forget to pay it or need it years later.
Exactly, even if it's irrational. The fear of forgetting seems to be a major driver, even if objective memory tests are sometimes inconsistent across studies.
And this connects to executive functioning, things like planning and decision-making.
Big time. Significant deficits are common here. trouble with inhibition-resisting urges to acquire or save, difficulty planning and initiating tasks, knowing where to even start with decluttering, extreme indecisiveness, agonizing for ages over one item, problems controlling interference, staying motivated. It all makes tackling the clutter feel paralyzing.
Wow. And then there's categorization, how they sort things.
Yes, this is key too. They tend to have an under-inclusive categorization style. Instead of broad, useful categories like clothes or bills, they create tons of tiny, specific, often idiosyncratic piles, like receipts from Tuesday or blue things I might use someday.
Making organization practically impossible.
It contributes massively to the disorganization and clutter. Studies show they take much longer to sort, get much more distressed doing it, and end up with way more piles than others. It's a fundamental difference in how their brain processes and organizes information.
That really helps understand the why. It's neurological, not just laziness or choice. Okay, and related to this, but rarer, is something called Diogenes syndrome.
Right. First described in the 60s, named in the 70s, ironically, after the Greek philosopher who rejected possessions. It's uncommon, maybe 5 per 100,000 people.
And the key features.
There's one major criterion: a profound inability or refusal to seek medical or social help, even when desperately needed. Extreme self-neglect and withdrawal.
Okay. And the minor ones.
You need one of 3 minor criteria: a pathological relationship with the body, severe self-neglect, illness; a pathological relationship with society, extreme isolation, exclusion; or, relevant here, a pathological link with objects sometimes called silligomania, which involves hoarding.
Silligomania. So how does that relate to hoarding disorder as defined in the DSM-5? Is it the same thing?
There's significant overlap. Silligomania involves hoarding everything, leading to cluttered, unusable homes, very similar to the HD definition. The key difference often lies in the degree of self-neglect and social isolation.
So someone with hoarding disorder, particularly with poor insight, who is very isolated and neglecting themselves, they might fit either description.
Potentially, yes, especially older individuals who hoarded for years, live in severe squalor and are completely cut off. Their presentation might align very closely with Diogenes syndrome. So, while maybe not identical, they're closely related conditions sharing core features around accumulation and often self-neglect.
Okay, that clarifies the link. Now, shifting gears into part 3, let's look at the broader landscape, the other mental health conditions that often show up alongside hoarding, making things even more complex.
This is really critical because hoarding rarely happens in a vacuum. Our sources say around 75% of people with hoarding disorder have at least one other co-occurring mental health condition. 75%.
Wow, 3/4, that's huge. It means treatment has to be holistic, right? Not just about the clutter.
Absolutely, you have to address the whole picture.
So what are the most common co-occurring conditions?
Major depressive disorder,
Yeah.
MDD, is the big one. Over half the people with HD in some studies also have depression. And interestingly, it's significantly more common in hoarding than in OCD, suggesting a really strong link between hoarding and mood problems.
Okay, depression is major. What else?
Anxiety disorders are also frequent. Generalized anxiety disorder, GAD, that sort of constant excessive worry and social phobia or social anxiety. About 25% of cases have one of these. The social phobia makes sense, given the shame and isolation hoarding often causes.
And we mentioned ADHD earlier.
Yes, specifically the inattentive type, found in about 28% of people with HD, much higher than in OCD. And it's those inattentive symptoms, disorganization, losing things, distractibility that seem to predict how severe the hoarding is. Makes sense, right? Those issues directly impact managing possessions.
Totally. It's the focus and organization part, not hyperactivity. And what about the getting stuff side? Compulsive buying, things like that.
Yeah, the sources talk about acquisition-related impulse control disorders. This includes compulsive buying, kleptomania stealing, which happens in nearly 10% of cases, and excessively acquiring free things. Over 80% of people with self-reported hoarding struggle with excessive acquisition.
So is that a separate issue or part of hoarding itself?
The sources lean towards seeing it as part of the hoarding phenotype itself, meaning it's often a core feature of the disorder, not necessarily a separate comorbidity, and it absolutely needs to be addressed in treatment alongside the difficulty discarding.
And just to hammer home that OCD point, again, fewer than 20% of people with HD actually meet the criteria for OCD.
Right. It reinforces that hoarding is distinct, even though it relates to various disorders, likely due to shared underlying vulnerabilities. But it's not just a form of OCD. This understanding has been vital for developing the right kind of help.
Okay. Now, let's talk about older adults. The sources say hoarding symptoms are almost 3 times more common in older populations, like 55 to 94.
Yes, the prevalence increases significantly with age, and this brings a whole unique set of compounded challenges.
This raises an important question. What unique considerations pop up when hoarding gets worse or shows up more clearly in older adults, given all these extra vulnerabilities? It must be incredibly complex.
It truly is immense. Older adults have often had more years to accumulate, so the sheer volume can be greater, the patterns more entrenched. There's a much higher risk of serious injury from falls or things toppling over a broken hip for an older person is far more serious.
And their general health plays a role.
Definitely. They might have more physical health problems, maybe cognitive decline or dementia starting, making it harder to manage their environment, understand the risks, or even participate fully in treatment. Just getting around their home can become dangerous.
It sounds like navigating the support system could be harder too.
Exactly. Multiple medications, different doctors, maybe less familiarity or comfort with mental health services due to stigma from their generation. They often face more lost partners, friends, mobility leading to less social support. And many are on fixed incomes, making it hard to afford help or different housing options. It creates this perfect storm of complex, interlocking problems. Sometimes it tips into self-neglect, bringing in adult protective services.
A very precarious situation. And sometimes these situations deteriorate into what the sources call squalor. What exactly does that mean beyond just clutter?
Squalor implies extreme filth and decay. It's not just too much stuff. It's a breakdown of sanitation. Think active infestations, bugs, rodents, pervasive mold, rotting food, animal waste if animals are present. It can even involve deterioration of the house structure itself. It's a severe health hazard.
A grim picture. And within this, people create little zones for themselves, these nests or cocoons.
Yes, it's striking. Amidst the chaos, they carve out a small space, maybe a chair surrounded by piles, or a corner of a bed where they try to live. Psychologically, it seems like a desperate attempt to create a tiny bit of order or safety in an overwhelming environment. A small, manageable bubble, even if the surroundings are dangerous.
Another really challenging form is animal hoarding. It's not just about the number of animals, is it?
No, absolutely not. It's defined by the failure to provide minimum standards of care, nutrition, sanitation, vet care, space. Someone could have just a few animals but fail to care for them and fit the definition. It's about the quality of care, or lack thereof.
And a key feature here is that profound lack of insight.
Yes, it's a hallmark.
Yeah.
They consistently fail to see or act on the animal's deteriorating conditions, disease, starvation, even death. They ignore the unsanitary environment, the overcrowding, and crucially, they don't see the negative effects on their own health or their families. They're often utterly convinced they're rescuing or loving these animals despite clear evidence otherwise.
That's a really stark example of how deeply entrenched these beliefs can be. The intention might be there, but the insight into the reality is just tragically absent. Are there specific health risks with animal hoarding?
Oh, absolutely. Air quality is a major one. Ammonia levels from urine and feces can become dangerously high, causing serious respiratory problems for humans and animals. Often levels are way above what OSHA considers safe for workplaces. First responders frequently need respirators to enter safely.
Wow.
Plus, there's a higher risk of zoonotic diseases, things that pass from animals to humans because of the close contact and unsanitary conditions.
And what's the prognosis? Especially with that lack of insight.
Like with object hoarding, the relapse rate for animal hoarding is near 100% without ongoing monitoring and treatment for the underlying issues. It's chronic. The sources stress that fixed belief I'm helping them makes intervention incredibly tough. It requires a very persistent, specialized approach.
Okay, so moving into part 4, it's clear that helping someone with hoarding requires immense nuance, empathy, patience. Let's talk about pathways to support, starting with the practical side of just working with people.
The sources really hammer home the importance of the interpersonal approach. It's all about building trust, building a relationship, before focusing on clearing clutter. It's a long game.
So not just marching in and telling them what to do.
Definitely not. Practitioners are advised to use cultural humility, being aware of their own biases, and curious, non-judgmental questions. Things like, tell me about this collection, or help me understand why this is important to you. Open-ended, showing genuine interest.
That sounds much more respectful, especially given the shame involved.
It's foundational. Using empathic statements is also key. Sounds like you're feeling really worried about letting that go, or I can see how hard this is for you. And when safety is a concern, using statements of concern, I worry that, or I'm concerned because. The first step is always safety assessment, immediate risks like fire hazards, blocked exits. But then it's about developing a plan with the person, collaboratively,
Which is the opposite of a forced cleanout, right? How do the sources view
as
those?
an absolute last resort, only for immediate, critical danger that can't be managed otherwise. And even then, the sources are blunt. Forced cleanouts have a poor outcome long term. They're often traumatizing, they destroy trust, and the stuff almost always comes back because the underlying issues aren't addressed.
So the preferred way is slow, gradual risk management, building trust.
Exactly, working at the person's pace.
This focus on autonomy brings up mental capacity. There's specific legislation, like the Mental Capacity Act 2005 in the UK, that guides this.
Yes, and the principles are really important globally when thinking about intervention. The absolute starting point is you must assume a person has capacity unless it's formally assessed otherwise by someone qualified. That's principle number one.
Assume capacity first. What else?
Principle two, you have to take all practical steps to help someone make their own decision before deciding they can't. Give them information clearly, allow time, offer support. Principle three is huge for hoarding.
Hmm.
Someone isn't incapable just because they make an unwise decision.
So choosing to live in clutter, even if it seems risky or unhealthy to others, doesn't automatically mean they lack capacity to make that choice.
Exactly. As long as they can understand, retain, weigh the relevant information, and communicate their decision, they have the right to make it, even if we disagree. It protects their liberty.
That's a critical distinction.
It really is. Principle four. If someone does lack capacity for a specific decision, anything done for them must be in their best interests. And principle five. Always consider if the goal can be achieved in a way that's less restrictive of their rights and freedom. Least intrusive option first.
It really underscores that having a mental health issue doesn't automatically remove someone's capacity.
Not at all. Capacity is decision-specific and can fluctuate. There's a two-stage test. First, is there an impairment or disturbance of the mind or brain, like HD, dementia, etc.? Second, if yes, does that impairment mean they're unable to make the specific decision at that time? Unable meaning they can't understand, retain, weigh the information, or communicate. Someone might lack capacity for complex financial decisions, but have full capacity regarding where they live. Interventions must be proportional, always respecting autonomy when capacity exists.
So if someone does have capacity and is open to help, what treatments actually work? What's evidence-based?
Thankfully, there are treatments with strong evidence. The main one, the gold standard, is cognitive behavioral therapy specifically adapted for hoarding disorder, CBT-HD. It's not just generic CBT.
Right. Tell us about CBT-HD. What's involved?
It's a pretty intensive guided program, typically around 26 sessions, often over 6 to 12 months. It involves both sessions in the office and, crucially, visits to the person's home.
Working in the actual environment. That makes sense.
It's essential. The therapy itself combines several key components tailored for hoarding.
Okay, like what?
It uses motivational interviewing to help build the person's own desire for change, especially if insight is low. It includes training in decision-making skills, addressing those executive function deficits we talked about. A big part is exposure therapy, gradually helping people face the distress of discarding and resist acquiring new things. And finally, cognitive restructuring to challenge those deep-seated beliefs about possessions.
So it tackles the thinking, the feeling, and the doing. What are the main goals?
They're pretty practical. Increase understanding of hoarding, reclaim usable living space, learn to organize effectively, improve decision-making, reduce acquiring, challenge those unhelpful beliefs, and ultimately reduce the clutter significantly and sustainably.
Can you give an example of that cognitive restructuring? The sources mention downward arrow interviewing.
Yeah, it's a great technique to dig down to core beliefs. Imagine someone hoarding, say, hundreds of empty yogurt pots. The therapist asks, what's the worry about getting rid of them? Client. Well, I need them. They're useful.
Okay, standard response.
Right. Therapist uses the downward arrow. Okay, and if you didn't have them, what bad thing might happen? Client. I wouldn't have anything to store leftovers in. Therapist. And if you couldn't store leftovers? Client. They'd spoil. I'd have to throw food out. That's wasteful. Therapist. And what would it mean if you were wasteful? And boom, maybe you hit the core belief. Being wasteful is irresponsible, bad, or I might run out, or I'd feel like a failure.
So it gets to the underlying fear driving the saving.
Exactly. Then you can work on challenging that fear, that core belief, not just the surface thought about yogurt pots.
That's powerful. And the exposure part, how does that work with such intense distress?
Very gradually. You create a hierarchy, from least scary to most scary discarding tasks. Start small, maybe discarding something broken and clearly useless. The key is helping the person tolerate the anxiety, knowing it will eventually decrease. They learn through experience that the feared catastrophe doesn't happen. Frequent, consistent practice builds new skills and tolerance. It's about regaining control over the fear.
And does CBTHD actually work? What are the success rates like?
The evidence is strong. Sources suggest 70% or more see significant improvement after a full course. Real reductions in clutter, acquiring, difficulty discarding. It's very effective when people can engage with it.
You mentioned motivational interviewing, too. How is that used?
MI is great, especially when someone's unsure about change or has low insight. It starts with their concern, not ours. Maybe they say, my landlord is hassling me. The therapist uses that as the starting point to explore their goals and motivations for change, gently helping them resolve their own ambivalence. It focuses on building their importance of change and their confidence they can do it.
Meeting them where they are.
Mm-hmm.
Okay, but what if CBTHD isn't possible or there's immediate risk and the person is refusing help?
That's where a harm reduction approach comes in. The goal isn't necessarily to stop the hoarding, but to reduce the immediate dangers and negative consequences. It's pragmatic, focused on safety when treatment isn't an option or hasn't worked yet.
So, respecting autonomy but trying to make things safer, what are the principles?
Respect autonomy is number one. Operate on a good enough principle, make it habitable, not perfect. Accept that change will likely be slow, and always involve the person with hoarding as a key part of the team. It's collaborative, not punitive.
And the specific goals focus on safety, health, and comfort.
Exactly. Safety. Clear flammable stuff. Ensure 3-foot walkways, clear exits. Health. Access to bathroom washing, working appliances, safe food storage, trash disposal, pest control. Comfort. Address heating, cooling, ventilation, designated places to sit sleep. It's about basic quality of life and reducing immediate risks.
Makes sense. And finally, there's a tool to measure distress, SUDS.
Yes, the subjective units of distress scale. Basically a 0 to 100 fear thermometer. People rate their anxiety level. It's crucial in exposure therapy to track progress. They see their SUDS rating go down as they practice, which builds confidence that they can manage the distress.
This all sounds incredibly thorough, but also complex to implement, which raises a big question. How do we ensure these different approaches, trust building, capacity assessment, CBT, harm reduction, are all integrated smoothly, especially with co-occurring conditions and varying insight? That seems like a huge undertaking.
It is precisely the challenge, and it highlights why effective intervention usually requires a highly trained interdisciplinary team. Mental health pros, social workers, occupational therapists, doctors, maybe housing specialists or legal experts, all communicating and coordinating. Integrating these pieces, the relationship, the cognitive work, the practical safety stuff, is essential for providing compassionate, sustainable support. It's rarely a one-person job. It often takes a village centered on the individual's needs.
Wow. We have really gone deep into something many of us, myself included, probably had pretty simplified ideas about. It's genuinely eye-opening to grasp how deeply ingrained this is, the real-world impact, and the sheer amount of science and specialized care involved. It is so much more than just a messy house.
And if we connect this to the bigger picture, truly understanding hoarding disorder fosters that crucial empathy, right? But it also empowers us as a society to push for better, more accessible, more tailored support systems. Recognizing it as a distinct, treatable mental health condition, not some kind of moral failing, is the absolute first step for individuals, families, and communities to tackle this often hidden challenge. That understanding is where change begins.
So what does this all mean for you listening right now? Maybe it gives you a new way to think about the things in your own life, what they mean, the comfort they offer, maybe how easily that relationship could shift. Or perhaps it's a prompt to consider how we collectively can better support those who might be struggling silently behind closed doors, dealing with isolation and shame. What's the one thing that really stands out to you from this deep dive into the very complex, very human world of hoarding?